Yeah, good evening, everyone. So, welcome to this third session on adenomyosis and endometriosis masterclass. So, today we have an interesting topic which many people had requested us to discuss about, that is the Elagolix. So, there is so much hype about the medical management once Elagolix has come into the market that it can replace surgery, it can replace many things, and this is the new kid on the block, and everybody seems to be very excited and very positive. So today, every day I'm seeing one patient of all age group who is on Elagolix, and I'm also, like, I mean, very curious to know from the person who actually believes a lot in telling people what is the truth about the treatment in endometriosis. So over to you.
My God, never imagined this class will start with so much laughter, but it's
I'm
okay.
sorry. Yeah.
Okay, so two, three things as far as this lecture is concerned. Maybe this will be around 12 to 13, 14-minute lecture, and we are only going to talk. So see, I was the KOL for two separate companies trying to introduce Elagolix in India. All right. One lecture I attended, second lecture I could not go because I was operating a patient who the previous company had, prescribed Elagolix on. And that is the ground reality, right? And fortunately, even Vismay has joined. So he is going to give us a beautiful ultrasound perspective of this entire situation. But there are three very important things which you need to understand before I step into the drawing, before I step into the diagrammatic representation. Elagolix is basically a oral antagonist. All this while you were giving injectable antagonist, a small change in the molecular structure and post processing for the drug manufacturing allows us to give Elagolix in a sodium form. So it is Elagolix sodium basically, and it allows it to be capitulated in a tablet form. Of course, the post processing is good, and that is the reason it allows people to give it in a oral tablet which can go and get dispersed in the stomach and then get absorbed and then go and act. All right. So that is a very, very good innovation. It's a fabulous innovation. There is no question in that. Now, if you ever read the document submitted by the guy who founded Elagolix to the FDA, all right, they have made one line absolutely clear. I mean, in the entire FDA document, one line is very crystal clear that this is not a cure for endometriosis, right? So if a patient is listening to this, be very careful of what nonsensical promises you are going to be made that you take this tablet and your endometriosis will go away. It will get rid of it. You will become this, you will become that. That is purely marketing. And we'll come to that aspect. And since most of the gynacs have joined, it will really hit them hard as to how a company will try to market this product to you. Okay. So in the entire FDA document, not a single line has been mentioned about this, that it will cure the patient out of endometriosis, right? The only line which has been mentioned is that this is a second line drug for management of moderate to severe pain of endometriosis. That's it. The entire FDA document is based on that one line. This is a drug which is a second line drug. It is not the first line drug. What is the first line drug? First line is oral contraceptive pills, NSAIDs, and progesterone only. So that means Dynogest, correct? That is going to be first line drugs. If in case the patient is not happy with first line management, second line drug is going to be Elagolix or an oral antagonist, and it has been promoted and approved as a second line drug and nothing more than that, right? Now, this is what the truth is, correct? Now let's before we come to the marketing aspect of it, let's actually look at what is the data suggesting regarding this entire product. Okay, so when we try and look at the data, I will just try to share my screen. Just let me know if the screen is seen, guys.
Yeah.
Right. So I will just give you a very quick and a very fast understanding as to what all do we need to know. So we know that, we have the bladder here, we know that we have the vagina and the retroverted uterus, and we have the rectum here. And somewhere in the brain, you have the hypothalamus. And the hypothalamus is also going to have receptors for something called as gonadotropin releasing hormone. Now your antagonist is going to go and bind competitively to this GnRH receptors. So your elagolix is going to go and bind competitively with these receptors. And as a result of this, it is going to cause FSH, LH, estradiol, everybody to be reduced. All right. And as a result of this, the endometriotic lesion, let's say the deep endometriosis, which is growing here, okay, we have already discussed it has got ER beta receptors, that is estrogen beta receptors, lack of progesterone receptors, and some estrogen alpha receptors. So these receptors will not receive any estrogen. There will be no estrogen acting upon them, and that is the reason why these estrogen receptors will be downregulated, and the lesion which was secreting under estrogen beta, it was ending up secreting a huge quantity of PGE2. This PGE2 will basically stop, and because PGE2 will stop, moderate to severe pain which is related to PGE2 release is going to go down whenever the patient is taking Elagolix. So that is your mechanism of action. Obviously, when you try to study the data a little more, you will come to know 2-3 important things. The two types of packaging is available for this. One is tablet 150 mg and second is 200 mg. Okay. So there is a lot of crystal clear data available that most of the women are going to require a tablet of 200 mg to be taken twice in a day. According to the manufacturers, this combination 200 twice in a day can be maximum prescribed for 6 months and nothing more than that. 150 mg once in a day can be prescribed for 24 months. All right. That is according to the manufacturer. But if you give 150, this is the stark data. Here, only 55% of the patient will experience some benefit in the pain. But if you switch it to 200 twice in a day, around 70% of the patient are going to experience pain benefit. So then your question is going to come, then what happens to the remaining 30%? Right? The obvious question is, Are bhaiya, ye 30% ka kya? So guys, remember we had mentioned that PGE2 is highly polymorphic. Okay. And estrogen receptor is also highly dangerous. It is highly polymorphic and it is just one of the mechanism. As a result of this, any endometriosis which has already formed something called fibrosis, that is deep endometriosis, which has given rise to a nodule, and that nodule is causing pain. On that, your beautiful elagolix will have no mechanism of action. Simple. There are those 30% of the patients who are not going to experience any benefit, and there are those patients in whom, irrespective of dipping them into elagolix, nothing is going to happen. So obviously, in a common perspective, they will either change the doctor or they will go to Google, YouTube, and come to a super specialist, right? And that's a very important market now for us, because that is a beautiful market. Patient is thoroughly convinced, patient knows every damn thing, and the patient no longer believes in medical management. What is the biggest side effect of this drug, which we should know? Now, this is marketing. Okay, this is the beauty of marketing. See how one word in marketing can make you feel so confident, and somebody can take advantage of a good, well-drafted FDA document to make a fool out of a medical practitioner. What have we been told? The commonest side effect which a patient can experience is hot flush, because it is an antagonist. The patient can experience depression and mood swings, but that is very difficult to predict, because depression and mood swings can also happen to women who are in pain. Correct? The women can experience dizziness and fatigue. That is also very common. So these are mentioned. And then comes a very important thing: osteoporosis. Now we all know that these drugs cause osteoporosis because of bone mineral density weakness, because estrogen is very, very important to maintain that. And when you suppress estrogen, elagolix does not know that it is going and acting on endometriosis. So elagolix will go and act on estrogen receptors which are present everywhere, and simultaneously it will act on the bone as well. According to the research document and proven document which they provide, 200 mg twice a day causes approximately 2.5 to 4% loss in bone mineral density. That is massive. Okay. And simultaneously, this may be irreversible. Okay. Now, this may be irreversible is a tagline which is not taught to you when a pharma company representative, including national sales manager, is coming to you to promote this drug. He's not going to give you this line that Elagolix can cause irreversible loss of bone mineral density, right? There is no research, there is no paper, not even their FDA document which states that, okay, when you stop Elagolix, the bones will grow back like how it was. And this is a major side effect, okay, which you should counsel your women about, because very soon, as a practitioner who has prescribed Elagolix, you will very soon be going to the court when somebody is going to have a pathological fracture in the spine and somebody is going to report down that this was caused due to Elagolix. So don't worry, that time will also come and you will end up paying maybe 2 or 3 crore rupees as compensation because it was a proven complication which you did not mention about, right? The other common problem, which is very, very commonly seen, and I'm sure Vismay will agree because a lot of women come to us with this problem, and that is hair fall. Okay. And again, in my opinion, this hair fall, from what we try and understand, is an irreversible loss. I do not know why this happens, but I think it happens to a lot of women. Okay. To a lot of women. So be very, very careful about this. Now, I have already told you that this does not act on deep endometriosis. But there is a very interesting part in the document where we try, we are very so worried about Shree guidelines. What did Shree guidelines say? I attended the entire Shree from outside. What did the guidelines say? I'm very curious to know. So remember, Shree has published one very clear warning in its 2023 endometriosis guidelines. So let me speak about that because that is very convincing to people. All right. To use it with caution and to use it as a second line drug, not as a primary line drug. That is one thing. Second, please note this down very categorically, that when you use Elagolix, there is no size criteria. According to their document, you can give it for 25 centimeter cyst, you can give it for 5 centimeter cyst, you can give it for 1 centimeter cyst, you can give it for 400 centimeter cyst, you can do whatever you want, because it is already mentioned in the document that it may cause a temporary reduction in size. That is written down. That okay, some reduction may occur, not compulsory and not guaranteed. The size may also increase. The nodule may be as it is. Only thing which will happen is that there will be a 70% reduction in the pain, in moderate to severe pain. That's it. The entire document only states that. So when you try to define a beautiful criteria, my patient is undergoing fertility, and that is the reason why I give Elagolix. My patient is my patient is not wanting to undergo surgery right now, and that is why I'm giving her Elagolix. My patient is having pain, and that is the reason why I give her Elagolix. You can cook up any indication. My patient fought with her husband. That is why I'm giving Elagolix. Even that is a completely normal indication, because no indication has been mentioned, no criteria has been mentioned, and that is why anybody can prescribe. You can prescribe endometriosis of the brain cured with Elagolix. No problem. Document does not support it, but you can give it. It is also categorically mentioned that post-operative Elagolix is purely under research. After you do the complete surgery for excision of endometriosis, it is a purely research driven at the moment if you have to give Elagolix or not. One thing, for an Indian woman, it has been also described, and many companies are going to tell you that you give it 200 twice in a day. Okay. And that is been written down that it is maximum 6 months. And it is also categorically stating the same document. It is available online. You can just Google it. I have no stakeholdings at the moment in any of the companies which are manufacturing Elagolix. It has also been written down very categorically that this is a very expensive therapy. So if somebody is prescribing Elagolix, they will know the price of a tablet. One 200 mg tablet is going to cost approximately 300 rupees. Okay. If you give this 200 mg tablet twice in a day, it comes to approximately 500 to 600 based on whatever your deal is, right? Whichever conference you are attending and whatever you are worked out, correct? Based on your deal, it will come to approximately 500 rupees pakad ke chalo for a single day. That comes to approximately 1 month of around 15,000 rupees. Okay. 15,000 rupees multiplied by 6 months comes to 90,000 rupees. If you call a traveling endoscopic surgeon in your hospital and ask him to do surgery for endometriosis, and if you by mistake give him 90,000 rupees, after collecting that, he will die of heart attack. Because that much money, nobody would have given it to him in his entire life for a single surgery, right? So when people try to speak nonsensical shit that it is so costly to get endometriosis surgery done in Mumbai or in India, I don't know which country and which people they are referring to, because India is something where talent is available so cheap and this drug is so expensive. And all the other while, when we talk of Dynogest, we are busy discussing how expensive one Dynogest is, where a 28-day therapy is going to cost maybe 1,500 rupees. And we don't mind shifting the patient to Elagolix, which is going to cost 15,000 rupees to the patient. So by mistake, if in case we are genuinely concerned about the cost to the patient, then definitely this is not the drug which you should be prescribing, isn't it? Because the options for getting surgery done in India are much more cost effective. That is one. And now finally, see, Europe currently has not commissioned this drug. Okay. At this moment, there is no commissioning in Europe. At this moment, from what I know, and I could be slightly wrong, from what I know, very few countries in Asia are using it. Okay. India is obviously the biggest market for this drug after United States and Latin America. It is not very severely promoted even in Middle East, okay, and definitely not in Africa. So what is going to typically happen is that when a drug is pumped in, so if you look at the data now for India, you will have around 23, I think 23 companies who have manufactured Elagolix in separate batches from the same company with the same API, with the same pharmaceutical ingredient, and with the same processing unit. It's not a very heavy processing unit. You will have a lot of Elagolix in different brand names, which is going to be flooding the Indian market very soon. And as a result of this, once a batch is manufactured, the batch has to be used up. So all innovative practices of marketing are going to be employed upon. And every pharmaceutical professional knows that these gynacs are scared of the bowel and the bladder. These gynacs are scared of the ureter. Catch hold of that and उनको Elagolix चिपका दो and tell them that no problem madam, no problem sir, surgery नहीं होना है, जरूरत ही नहीं है surgery करने का, just give Elagolix, right? What I want to drive home through this last 1 minute is, guys, if you are not going to be doing and giving Elagolix to your sister or to your wife or to your daughter, then probably you should not be giving Elagolix after listening to this to your patient as well. Okay. And if you really want to give Elagolix to your patient, you at least take down in writing so that you as a gynecologist are safe, that you have explained everything. And after explaining everything, if the patient wants to take a temporary management for reduction of pain, she is entitled to do so. But at this moment, as we speak in 2025, according to any guideline which you study, ultimately after all of this, or for those 30% of the patients who don't respond to even second line management, the treatment of choice is going to be operating them and doing nothing else. And when you talk of operating, as somebody mentioned before the lecture started, they have seen the surgeries, but they are not very confident on handling the bowel. Guys, remember one thing. Nobody is born with this talent. Okay? Absolutely no one. I can probably share journey of Shilpa madam. I've seen her operating when I started to going to Bangalore. She's a fabulous surgeon. But she was not very sort of very much confident as far as retroperitoneum is concerned. She is a very strong-headed lady. She does not really care of bowel, bladder, ureter, vessel, nothing. Everything which comes in her way, if it is wrong, she will just destroy that. But once madam started operating in the retroperitoneum, I have seen her change, and I have seen her operating and doing video calls to me in between the surgery that, okay, shall we cut here? Okay. And all it takes is training, confidence, and that one bolt cut. If that one bolt cut goes through the right plane, you will give excellent pain relief to your patient, and that patient will absolutely vouch for the surgery for the rest of their life. And I think if people like me can do it, Vismay can do it, Shilpa madam at age, I think she's 41, 42 years old now. And at her age, if she is able to learn the trick despite having such a busy practice, then all of us should be able to do this and give the right treatment to our patients and use these drugs like how they are supposed to be used as a second line management of moderate to severe pain in endometriosis for a temporary management, right? I'll be happy to answer more questions. I overshot by around 2 to 3 minutes, but I'll be happy to answer.
Okay, so see, when we talk about medical management, usually it evolved from ocipils to progesterone, and then newer progesterone, and then the GnRH agonist injection depot, and then to the Elagolix now, which is there. So in the past couple of months, like how you said, there are more than 20 companies which are manufacturing, and everybody wants to, like, push their product to the practitioners. And now that the incidence of endometriosis is so high, so every day, like, because I think we have been quite prominent in terms of like bringing up awareness for these cases, and that's why we get so many referrals every day. I'm seeing one adolescent today. I saw a 19-year-old with endometriosis. Yesterday I saw an 18-year-old with endometriosis who are already on an Elagolix, and they kind of like, they are unsure because they have 10-centimeter endometriotic cyst, and they don't know, and they think that this is the most fanciest medication that is available because it is expensive, and they are quite safe. So how do we actually, like, I mean, they're not aware of the consequences, nor are they aware of what is the right treatment, because they think the more money they spend, the better it is for them to control, or probably, like, the disease can be cured with this.
I hope they start thinking that the more money they spend, the better it is when they come to me. That is the first thing. Second, uh, see, as patients, madam, they have no medical legal liability on them. Correct? As pharma representatives, they are not qualified doctors. They don't even have a medical legal liability on them, irrespective of what shit they speak. It is our responsibility as healthcare practitioners to go through something called as package insert, which is provided with every strip mandatorily as far as the DCGI rules of India are concerned. And this package insert is provided so that when a doctor is prescribing somebody a particular medication, he reads through the package insert and he tells the patient that this is what is going to happen, right? Now, majority of the times, all of us, apart from me, are very busy into practice. And so what typically happens is we don't really get the time to go through these documents carefully, right? And because we don't go through these documents, we listen to what people tell us on hearsay, correct? And as I told you, a very important word will never be spoken. They will never tell you that it is irreversible bone loss. Okay. The chances of recovery are unknown. This is written in their FDA document. Correct. This is never told to us as gynecologists. We are only told, kuch nahi hota hai, madam, chalta hai, sab kuch, that is
Yeah,
how
yeah,
we are told this. Okay. And that is
yeah,
how we believe people. Correct.
yeah.
If somebody has a pathological fracture, and we, myself and Visma, have admitted 2 patients in the last 4 months with pathological fractures in our hospital. One was spine fracture, another was hip fracture. Okay. On Elagolix. So now when this 18-year-old lady goes to court, okay, the minimum compensation is 3 crore rupees. And probably all what you are going to get out of prescribing Elagolix is a fancy discounted purse, and nothing more than that. So in that situation, one has to be really, really careful before putting your foot down and writing this drug with the confidence that you're going to tell the patient that nothing will happen. Go.
Okay, see the scenario in a clinic. Okay,
Yeah.
forget about you, me, Aarti, or even Padmapriya. So the clinic situation will be like the parents will come with a
Yeah.
adolescent or a infertile the girl who is young and who has severe endometriosis, who is in terrible pain. So
Yeah.
the first thing that they don't want to do is surgery. So
Correct.
in your clinic, I know your way of counseling, but in a toned down way of counseling, how what are the points that you put across? I know you will tell a pathological fracture and all these things as the first thing, but how to, I mean, give it to them like more diplomatically. Forget about,
No,
like,
I am actually a little, I don't know. I am not a very diplomatic person, any which ways. So, what we try to talk to the patients is this, that as far as the disease is concerned and the pain is concerned, if the size of the disease is more than 3 centimeters, that's a guideline. And if the patient is having pain, that is a guideline. And if there is a presence of a nodule, that is a guideline. Correct?
yeah.
If it is fitting into these 3 criteria, we will operate. If you think you don't want to operate, no problem. Go.
Okay.
Right?
Okay. Stop. Yeah.
Simple.
Yeah. And you have seen people who were on like, multiple doses. I know
Yeah.
you have operated on a young girl with who had taken more than 20 doses of Lupride depot.
Yeah.
And then now you're seeing young girls on Elagolix who come with like, severe hair fall, depression probably, and a lot of other stuff as
Yeah.
side effects. So in between these two set of people, I mean, who do you think like, are worse like compared to what you saw in like past 2-3 years back to now? You think Elagolix has more side effects more rapidly because even though it is such a new drug, we see so much complication and
Hair
still
fall.
like,
Hair fall. Oh God, you should believe. I don't know how to. I mean, I'm growing my hair, but I know how it feels to lose hair now. Okay, it's so crazy. These are young girls, maybe 25, 26, 27 years old, and they really forget the pain. That is the there only. Apart from that, they lose hair. They lose their beauty also. Whatever little is there. That is another pain point. And that is so depressing. Believe me, it is so depressing for these girls that they are like, "Arey yaar, we don't want to take this. I'm losing my hair also. Pain is," and don't be in that impression that they're absolutely painless. I actually wanted Vismay to elaborate on the pressure points, because whenever you touch a nodule, even if the nodule, even if the patient is on Elagolix, Arey, she will wince in pain.
okay, okay, fine. So we'll ask Dr. Vismay whenever he's free. We'll ask him to join our next class. Today we have overshot our time. You have
Yeah,
overshot. So thank you very much. I think this was a very good class. In fact, when you search on YouTube, only your shots come on Elagolix and nothing else actually. So this
I
may be
know.
one of the first few videos which will actually come out as educational and as practical as possible for practitioners across the world to understand the practical problems. I mean, every day I am like, seeing so many patients, and you are seeing like probably multiples of what I see. So this should be something which is like, an important class that everybody should see before they actually start prescribing newer drugs. So, Arti, if you have any question, I think you should conclude.
Yes.
I wanted to add one thing. The document also categorically states that Elagolix has got no role in adenomyosis. So if in case somebody is wanting to give Elagolix because somebody is doing FET cycle and there is just a 7 centimeter adenomyoma and they want to give Elagolix for that, Elagolix has got no role in adenomyosis, and that has been categorically stated in that document. Of course, when we touch adenomyosis as a pathophysiology, we will prove why estrogen receptors have got no role in adenomyosis. But yes, sorry, I wanted to just mention that.
Yeah.
Jay, I have one question to ask and one just food for thought, just to
Yeah.
end the session with. So one question is, if the patient, you beautifully elaborated the good and the bad of Elagolix. Now, if there is a patient who's gone in for surgery, she's had a recurrence of symptoms like Dr. Mehdeep had mentioned, he sees very often in his practice, and
Yeah.
the patient now is very skeptical about going in for surgery, but she's having a recurrence of pain.
Correct.
In this group of patients, would you want to give them some sort of a medical management?
So two things are very important here, ma'am. Was the first surgery a complete surgery? Was the first surgery a completely excisional surgery or not? Correct. That is the first thing. Let's assume that was. And if the patient is having recurrence of the disease, which can happen, okay, in some women, despite doing everything correctly. And if now the patient is skeptical, you can, provided you as a medical practitioner has written down that they need to make up their mind in the next 5 months and then come back to you. Correct? Because the maximum time limit is 6 months.
Right.
That is one. If the surgery is incomplete, which it is in more than 90% of the cases, people will do ovarian, ovariolysis, ovarian anatomy will go back to normal. Bowel nodule will be as it is. Understanding? And we see that. I mean, we see that very commonly in Bombay, Bangalore, Hyderabad, Chennai, everywhere, right? So till you don't go and remove that nodule, you have done maybe 25% of disease clearance. So 75% was pending any which ways. So the patient really understands it these days, and then they come back for surgery.
Right. And what about the young unmarried girls?
Yeah.
Then they may go in for surgery. But again, most of the gynecologists are skeptical and worried that it's going to recur because they have a very long,
Correct.
they have a long reproductive lifespan
So,
ahead. So in
so
this group, again, would you want to, consider this to sort of reduce the recurrence?
no. So post-operative Elagolix has not been proven to be of any role. If in case you have done a complete surgery for microscopic disease, if in case you want to do something, then you should go back to the first line management, and that is oral contraceptive pills and not Elagolix.
Right. So you give them the 100-day pill and just
Correct.
allow them to have 3 to 4 periods.
3 periods
That
in a
is
year.
that's
Our
our
protocol is
protocol.
3 periods in a year and
Right.
give them 100-day pills.
Right. And just one last food for thought, Jay, to end the session is, see, these medical managements like Elagolix, Dynogest have a place in the market for 3 reasons.
Yeah.
One, because a patient is frightened about surgery and we tell them about all the risks of surgery. So they also take a step back and they don't want to consider it immediately.
Yeah.
Right? That's one reason why these medical managements have a place. Second is the gynecologist is not well versed, like you mentioned, with, doing such an extensive surgery, especially doing so much of bowel surgery.
Yeah.
And third, even after you do a good surgery, it may still recur. So that is where that fear-based marketing, you get surgery done, it's risky. You get surgery done, it may come back.
Correct.
That is why these medical managements have a role.
Correct.
Okay, that's the truth of the matter.
That's the name of the topic, right? Fear-based marketing.
Exactly.
So it plays on the fear of everybody, and it really works well. See, if I tell you don't do this, correct? Somebody will kill you. Then of course you are not going to do that. You are going to be very, very skeptical, right? That's why I was giving that example of marriage, to one of our colleagues before this class actually started. It's as simple as that, madam. No matter what you do, your wife is going to get angry on you, even if you've done the right thing. Something like that is the fear-based marketing for this product.
Right. So this is the fact, and because of which medical managements are still being used out there. And so, of course, we have to, classes like this, like Shilpa said, is very useful for awareness. And one take-home message is, if you are writing these sort of treatments for whatever reason, take it in writing that everything has been explained and it's the patient's choice. And two, I don't know whether we need to also focus on prevention in future, maybe when you talk about gut dysbiosis in future, and
that was actually to be spoken today, but now it will go to Friday.
Right. So
will not go to any day.
We should talk about it sometime though. Right. So yeah, we have to think about prevention and how what are the reasons in the environment which are sort of causing endometriosis to be so rampant out there sometime in the next few classes, Jay. So this was just a food for thought.
Yeah.
So yeah.
Thank you so much, all you beautiful people, except one person. Thank you very much.